All right, so start off with a question first. You have a 23-year-old patient that comes to GP with lower abdominal pain, which has been there for about 6 months. And she says it radiates down to the pelvis sometimes. And she has pain whilst passing stool. Her gynae history is she's not been pregnant, but she is sexually active. What would you think is the most likely diagnosis here? Is it IBS, pelvic inflammatory disease, adenomyosis, endometriosis, or celiacs? Give you guys about 15 more seconds. Majority of you going to the right track. I'll end the polls there. It's been a minute. All right. Yep. So most of you said endometriosis, which is the correct answer. So here, the slide's not working. There we go. Yeah. So IBS, it could potentially have been that because she's had the radiating pain, but with IBS, it's more likely to be brought on by some kind of food as well. There's no history of that. She is sexually active, so that was kind of a throw off for pelvic inflammatory disease, but she has no pain, so no dyspareunia or discharge as well, and she's not got any fever or any signs of like general illness that you would see with an infection. Adenomyosis or fibroids, they would cause abdominal pain and heavy menstrual bleeding, and an enlarged uterus. You might be able to see an enlarged uterus on physical exam as well. And celiacs, again, so it's more persistent unexplained abdominal pain with indigestion, diarrhea, bloating, and constipation. So again, these are all differentials for endometriosis, what I'm trying to get at. So start with endometriosis. It's defined as basically the presence of endometrial glands and stroma in anywhere except for the uterus. And this can be seen quite commonly. So it's seen in about 7 to 10% of the population. And the mechanism of how that happens is not fully understood, but there's 3 theories. So there could have been direct implantation of the endometrial cells by retrograde menstruation, or by vascular and lymphatic dissemination. So this is more to suggest for the distant endometriosis. So when you see it in lymph, pleural cavity or kidneys or anywhere else. And the last theory is coelomic metaplasia. So this is to suggest that the multipotent cells in the peritoneal cavity can basically become endometrial cells. Now, sorry guys, my laptop's been a bit slow today. Okay. So when we talk about the risk factors for endometriosis, there's no specific, but there's some that can increase your chances a little bit. So if you had sterilization, any kind of laparoscopic manipulations, if you've got family history, or if you've gone through early menarche, or if you've never been pregnant. And presentation of endometriosis is normally chronic pelvic pain. So it's normally said to be 6 months have cyclical pain or continuous pain. And they can have secondary dysmenorrhea, which often starts days before bleeding. and this normally affects their normal daily life and quality of life as well. They can have deep dyspareunia or pain after sex or during sex. They can have also non-gynecological symptoms such as pain whilst defecating, so dyschezia, or pain whilst urinating as well, or blood in urine. And when you do a physical exam on them, you might find like a reduced organ mobility and like tendon nodularity in when you do the exam. So these are just some of the common places that you can find endometrial cells. So you can find them in the pouch of Douglas, around ligaments, fallopian tubes, sigmoid colon, and rarely it can actually be found in scars. So if you've had previous surgeries. And when you're diagnosing endometriosis, so laparoscopy is the gold standard investigation, and you can't normally diagnose them without a laparoscopic test, without doing a laparoscopy. But you can do a physical exam, like I said, and you should also look at the risk factors that they have. So with the laparoscopy, you can do a biopsy and send it to pathology to make sure there's no signs of cancer as well. And you'd be looking for at least 2 or more of the following: so endometrial epithelium, glands, stroma, or hemosiderin laden macrophages. And sometimes in primary care, they do use ultrasound, but it's not that helpful, but it can be a good starting, I guess. And so management for patients with endometriosis is, firstly, you need to manage the pain. So that can be done with simple analgesia, so paracetamol or NSAIDs, and that's the first line for symptomatic relief. If that doesn't help, then hormonal treatments are available, such as the combined oral contraceptive pill or progesterone pills, or you can use the Mirena coil. Surgical management can be done, but it's normally saved for really severe cases, which would involve laparoscopic resection, and you would have to do 3-month treatment with gonadotropin-releasing hormone agonists afterwards. And yeah, normally you want to excise the region rather than doing ablation. And hysterectomy can be done if the patient does not obviously want to have any further children. So now moving on to PCOS. So does anyone know the patients that have PCOS, what are they at higher risk of? Is it hypertension, melanoma, endometriosis, diabetes, or ovarian cancer? Give you guys another 15 seconds. Majority again this. There's still 10 people that haven't tried. You might as well have a go. I'll end the polls there. Yeah, so the correct answer is diabetes. So, Yeah, there you go. Patients with PCOS are actually at high risk of a lot of other disorders, mainly being infertility, dysfunctional bleeding, endometrial cancer, obesity, sleep apnea, type 2 diabetes, as I said. They're also at high risk of dyslipidemia. They can also have cardiovascular diseases, and it can also be familial, so inherited. So the etiology for PCOS is not fully understood. It's thought to be both due to hyperinsulinemia and high levels of LH. And there's a really it's really underdiagnosed because the patients are not sure who they go to see, because the disease lies with endocrinology, dermatology, and gynecology. So as of now, there's about 6 to 8% of women that have been diagnosed. Again, it's more common in obese women, and also more common in Arabic and Asian women. So yeah, so like I said, there's two types of PCOS. There's the LH driven, in which the women are normally thinner. They have high LH levels. They have high impaired glucose tolerance test, and they respond to ovarian diathermy, which I'll get to later on what that is. And there's the insulin driven one, in which the patient has a lot of centripetal fat. They have acanthosis nigrans, and they have a longer intermenstrual interval. So, yeah, like I said, the etiology isn't fully understood, but there is thought to be some genetic predisposition if you have obesity and other causes that may cause you to have a high amount of LH. And it's thought that it's the ovaries that are more responsible for the androgen irregularity than the adrenal glands. So the way that this works is, if you have insulin resistance, you're going to have obviously increased levels of insulin. This then increases your testosterone and also inhibits your sex-binding globulin, and that then causes your androgenic effects such as the hirsutism, acne, irregular periods, and fertility. And diagnosing PCOS is quite hard, and it can have a lot of differentials. So Cushing's, adrenal or ovarian tumors, you can have congenital adrenal hyperplasia, menopause, exogenous substances such as anabolic steroids or testosterone medication, or if you have any thalamic or pituitary disorders as well, that can cause similar symptoms. So patients with PCOS, they normally have obesity, and 50% of them have more towards abdominal and central obesity. This then therefore means that they are more likely to have metabolic syndrome and hyperlipidemia as well. They also have acanthosis nigricans, which you can see here in the picture. So they're like black striae, normally seen around the armpits or the neck and like any region with creases. They have oligomenorrhea. They have also menstrual dysfunction and anovulation with irregular menses, so which is defined as being either less than 21 days or more than 35 days. And normally it's more towards the prolonged period, so they have more than 35-day cycles, and they can have erratic menstruation as well. They commonly have less than 6 spontaneous bleeds per year. This then means that there are increased risk for endometrial cancer and endometrial hyperplasia as well. They also have commonly hirsutism, so hair growing from different places, and that can be measured by the Freeman-Galloway scoring seen here. They can also have acne, seborrhea, male pattern balding, increased muscle mass, deepening of the voice, and infertility. So majority of the women actually come presenting due to the hirsutism and acne troubles. So diagnosis. So there's two different criteria that people use. There's the NIH consensus and the Rotterdam criteria. I think the Rotterdam criteria is more commonly used. So the Rotterdam criteria, you need to have oligo or anovulation, clinical signs of hyperandrogenism, which means either your LH is decreased, your FSH and your testosterone levels are also measured. You also measure your free testosterone and your sex hormone binding globulin as well. And you do an ultrasound of the ovaries, which will show polycystic ovaries. Where normally you want to see more than 12 cysts. And the NIH consensus is, again, menstrual irregularities, clinical or biochemical signs of hyperandrogenism, and you want to exclude any other causes for hyperandrogenism and anovulation. So commonly when you do the ultrasound, what you see is beads on a string appearance, or is what's described as beads on a string. Oh, sorry. So the cysts, they present and they look like little white beads along the ovaries. You can also do a thyroid function test and, like I said, the hormone profile. So when you do the hormone profile, you can also calculate the free androgen index, which is basically the total testosterone times by 100 and divided that by the sex hormone binding globulin levels. And you would also want to do lipid profile and insulin levels, as they're high risk for metabolic syndrome and diabetes. So when you want to manage patients with PCOS, the first important thing is to manage their weight, because that's the main factor that affects most of their symptoms. So normally patients are asked to reduce weight as the first line management, and that has shown to help infertility a lot. So if you lose, I think, depending on the size, but even losing 5 to 10 kilos has helped increase your chances of fertility by 50%. So you want to, but obviously when you give them goals, you want to give them realistic goals, and you want to refer them to a dietitian as well, so to help them manage their weight. So for hair removal, there is things such as eflornithine, but it's quite expensive, or you can use anti-androgen therapies such as spironolactone. For the anovulation, you can use oral contraceptives. So with this, the advantages are that there's regular withdrawal bleeding, so it decreases your risk for endometrial hyperplasia and endometrial cancer. So yeah, and for the infertility, you can use clomiphene, which is the first line treatment, and has shown good results. Or you can do surgical management such as ovarian drilling. So this is where holes are basically drilled through the ovaries, and that has helped to show patients success. Patients have had success with fertility after that. They can also go through the IVF route, and like I said, weight loss is a very important part. So talk about infertility now. So after what age do you think the women have the biggest decline in viable ovarian reserve? Is it 25, 35, 40, or 45? So basically another way of saying is, after what age do the eggs start to deplete? The number of eggs. It's a good spread of answers. I'll give you guys a little bit more time. All right, last 20 seconds for anyone who's not answered yet. Just want to get your answers in. Right, and then the polls there. Yeah, so there was a good spread of answers, but yeah, majority of you are correct. It is 35 years. So there's a graph here you can see. Second. There we go. So it's normally after 35 that you have the biggest decline in your fertility, up till obviously menopause, which is around 50, 52 years. So the definition of infertility is when a woman of reproductive age who has not conceived after 1 year of unprotected sex, vaginal sex obviously, in the absence of any known causes of fertility. And you have two types. There's primary, which is when you've never had previous pregnancies, and secondary, which is when you've had a previous pregnancy regardless of the outcome. So you may have had a successful or unsuccessful pregnancy, but now it's been more than a year since you've not been able to conceive. So etiology, 40% of the reasons are male related, and this little chart here shows the causes of male related infertility. There's a lot of reasons going from external, so your occupation, age, BMI, recreational drugs, chemo, radiotherapy, if you've had any previous surgeries around your genital region. They can also have congenital disorders, so cryptorganism, any kind of Klinefelter's or Kalman syndrome, or it could be acquired. So if they've got any kind of malignancies or infections or recurrent infections, that increases their risk. They can have endocrine disorders, so pituitary or hypothalamic disorders. Again, genetic, so molecular or structural disorders they can have, and they can have sexual dysfunction, so erectile dysfunction or anejaculation. Obviously, some of these do obviously so the same risk factors for women. So your age, BMI, lifestyle factors, endocrine dysfunction, they're all similar to women. But in women, other causes are endometriosis, ovulation problems, blocked fallopian tubes, or they can have unexplained. And differential diagnosis for infertility would be anovulation, PCOS, hypothyroidism, or hyperprolactinemia. So when you are examining a patient with infertility, the first few things you want to check, basically, there you go. You want to take a detailed history to make sure to rule out any kind of PCOS, like take their menstrual cycle history, see if they've got any signs of acne or hirsutism or any family history. For women, you want to do a full hormone examination. So check the LH, FSH, all the hormone levels. You want to do an ultrasound exam to make sure that the tubes are patent and there's nothing blocking them. For male, you want to do semen analysis at least 2 times, so 2 different samples. And again, you want to do a hormone assessment. And if there's any kind of issues or concerns regarding genetic issues, you can do genetic tests or karyotyping. And here's just a reference value of the semen analysis. So you're looking at the volume, the pH, the concentration of sperm, the motility, so the concentration of the sperm that are actually motile, and the morphology as well. Now, treatment. So there's a lot of different ways of treating infertility. So firstly is assisted reproductive therapy, so IVF. The issues with IVF is that it's quite expensive, firstly. And there's also risk of twin pregnancies, which happens in about 50 to 20%. And IVF basically works by externally collecting the eggs from the women and externally collecting the sperm. And the egg is then injected with the sperm under a microscope. And once the embryo reaches about day 5, it's inserted back into the endometrial cavity. And then a pregnancy test is done to make sure that there's a viable pregnancy. Then you can also do surgical correction if there's any kind of anatomic anomaly. So if the woman has any kind of fibroids, or if there's any obstruction in the tubes that's causing blockage, such as previous adhesions. So if she's had previous surgery that's caused adhesions, you can do surgery to correct that. For men, you can have, if they've got erectile dysfunction, then you can do IVF to remove the sperm. And if they have no sperm, then it's a bit difficult. So next question. It's actually the final question. You've got a 27-year-old woman with PCOS who comes to a GP and she wants to have a baby with a partner. The GP recommends weight reduction, which has resulted in her BMI of 24 now. However, she's still anovulatory. What would you suggest the best treatment is next? Clomiphene, continue weight reduction, gonadotropin induction, IVF, or metformin? Just read on the pause now. Right, yeah, the majority of you get this. Give you guys a little bit more longer to. Last 20 seconds for anyone who's not answered. Just get your answers in. I'll end the polls there and share results. Yep, perfect. It is clomiphene, guys. If you remember, that was the first line treatment for inducing ovulation in patients with PCOS. just how it works, if you want to know, is basically antagonizes estrogen receptors in the hypothalamus and pituitary. So it basically increases your LH and FSH by negative feedback, which causes the induction of ovulation. With her weight loss, she's already within normal range now, so that would, her continuing to lose weight would not make much of a difference, because although that can help, in this case it's not helped. So gonadotropin induction, it is second line now for inducing ovulation. So in that, you'd normally do a subcutaneous injection of either FSH or LH to basically stimulate the follicles. And normally ovulation is then triggered by a single HCG injection, which is given intramuscularly. IVF, again, you can do that, but that's not first line. And metformin can be used with clomiphene or as an alternative, but it has a lower live birth rate than clomiphene, so should be given if clomiphene fails to induce ovulation.